So I think we have to start off with what is endoscopic management of kidney stones. And this basically describes a way of treatment of stones where rather than in the past we make an incision or cut in the body to get to the stone, we now have scopes that can basically go up to the natural passages of the body, i.e. the urinary tract, to the stone. We have baskets that can grab stones, and we have lasers that are able to fragment stones into small pieces. And in some circumstances on the right-hand side, we do a puncture into the kidney, but it's less than 1 cm puncture, and that allows us to treat even bigger stones in the kidney. Let's next slide, please. So initially, we were dealing a lot of issues with mechanical trauma when we talk about complications related to stone treatment. Next slide. And it would be things like this where, let's say we're trying to extract a stone with a basket, and in the process, we rip the ureter. You can see over here. And in the next slide, you can see that this is what happens also when we pass a small sheath into the ureter to try and get access into the kidney, and sometimes you can cause a tear in the kidney, in the ureter. And these were the problems we were facing, very much mechanical in nature. But over time, things have changed. We've tried to overcome this. Next slide. By a few things. The first is, in the past, we used to do fragmentation of stones and a lot of basketing, but I think there's a push towards doing dusting, basically converting a stone into dust fragments, allowing it to be washed out. And I think this is something that Dr. Heng later on will be touching on, the issues related to dusting, so I won't talk about that very much. A requirement, of course, to move from fragmentation to dusting is we need more efficient lasers, so we've gone to higher powered lasers to dust the stones so that we can try and avoid issues related to extraction of stone fragments and use of too large an excess sheath. So we can try and reduce mechanical trauma. Next slide. Unfortunately, when we did this, in terms of changing of our practice towards use of smaller channel devices to prevent injury to structures, more dusting, which means higher energy lasers, we end up with a different set of safety issues now. So we've moved over from mechanical trauma, which used to be the predominant issue, and now as we go to higher power lasers, we're moving more towards issues with regards to temperature and pressure, which can cause certain problems. As you can see over here, using a high power laser, a 40-watt laser, as you increase, if the irrigation is not sufficient, temperature rises quite significantly. So we know that normal tissue denatures at about 40 degrees, and the body temperature is already close to around 37 degrees. So you basically have a 5, maybe if you're lucky, a 10 degrees Celsius window to play within in terms of temperature changes. But as you can see, with a high power laser and with insufficient irrigation, you can easily hit 60 degrees or more when you fire the laser for up to a minute. So this can lead to certain kinds of trauma to the kidney. Can we see the picture? Next one. So here we can see a picture of a porcine model. This is a pig model where the use of high energy lasers without sufficient irrigation can lead to things like eschar formation and also beyond the initial surface blackening, there's also, you see white patches of ischemia and heat trauma going throughout the kidney. So we do try and manage these intravenous pressures by controlling irrigant temperature or irrigation flow, or even trying to reduce laser power settings. But once again, then this affects the efficiency of stone treatment. Next slide. So the second issue, of course, is as we try and reduce mechanical trauma, we have moved towards smaller and smaller excess sheath sizes to try and reduce trauma to the ureter. Unfortunately, when you do that and you're trying to maintain a certain degree of irrigation to prevent temperature rises, a rise in temperature, you lead to increasing pressures within the kidney. So the usual physiological pressure of kidney is around 10 cm water. With chronic obstruction, we get to 60 to 80. When we get to 40 to 45 cm water, we start getting what we call pylolymphatic or pylovenous backflow, which means that the fluid that are passing into the kidney through the scope is actually being pushed back into the tissue of the kidney. And this can lead to bleeding, like what we describe as fornicule rupture. And in fact, when we use certain pumps to maintain pressure, especially with a syringe pump or a hand pump, the pressures can hit 3 to 400 cm water. And this can lead to quite a lot of kidney injury, infection, and sepsis. And in fact, in up to 8% of these cases, or where we do RIRS, also called retrograde intravenous surgery, where we pass the scope into the kidney and treat stones, up to 80% of these patients will get some degree of significant sepsis. Next slide, please. So in conclusion, in our race to increase the efficiency of stone fragmentation and dusting and removal, attention must be also paid to safety. So with increasing powers of lasers and smaller access sheath sizes, we lead to problems with increased intravenous pressures and temperatures. And I think we're starting to see this as bigger significant factors for mobility as we try to use this same technology to treat larger and larger stones. Because the time required to laser a larger stone is much more than if you're treating a small stone. So I think the challenge is how can we design devices for better flow. I mean, firstly, we need to still prevent the mechanical damage of too big a device, okay? So we would want to have small devices, but at the same time try to maintain good flow so that we can still efficiently treat kidney stones and also not end up with too high a pressure or too high intravenous temperatures. Thank you.